According to the World Health Organization, cardiovascular disease is the leading cause of death worldwide, as well as in the US. Of those, a large proportion are caused by heart attacks, also known as acute myocardial infarctions, or just myocardial infarction, sometimes just called MIs. The word infarction means that some area of tissue has died due to a lack of blood flow and therefore a lack of oxygen. Myo refers to the muscle and cardio refers to the heart tissue. So, the heart attack or MI, you have death of heart muscle cells because of a lack in blood flow, a process called necrosis. Now, the heart's main job is to pump blood to your body. She's right. Well, the heart also needs blood, and so it also pumps blood to itself using the coronary circulation. The coronary circulation is the system of small arteries and veins that help keep the heart cells supplied with oxygen. Heart attacks happen when these small arteries become blocked and stop supplying blood to the heart tissue, and if this happens for long enough, heart tissue dies. Almost all heart attacks are ultimately a result of endothelial cell dysfunction, which relates to anything that irritates or inflames the slippery inner lining of the artery, the tunica intima. One classic irritant are the toxins found in tobacco, which float around in the blood and damage the cells. That damage becomes the site for atherosclerosis, a type of coronary artery disease where deposits of fat, cholesterol proteins, calcium, and white blood cells build up and start to block blood flow to the heart tissue. This mode of stop has two parts to it: soft, cheesy textured inner and the hard outer shell, which is called fibrous cup. Collectively, these whole things are ominously called plaque. Usually, though it takes years for plaque to build up, and this slow blockage only partially blocks the coronary arteries, and so even though less blood makes to the heart tissue, there's still blood. Heart attacks happen when there's a sudden complete blockage or occlusion of a coronary artery. So, let's see how that could happen. Since these plaques sit right in the lumen of blood vessel, they're constantly being stressed by mechanical forces from blood flow, and interestingly, it's often the smaller plaques with softer caps rather than the larger ones with harder caps that are especially prone to break or get ripped off. Once that happens, the inner cheesy feeling, which remember is this mix of fat, cholesterol, proteins, calcium, and white blood cells, is thrombogenic, and this means that it tends to form clots very quickly. So, platelets are blood clotting components in the blood flow and get excited, and they adhere to this exposed cheesy material. In addition to piling up, the platelets also release chemicals that enhance the clotting process. Now, this happens super fast. Think about how quickly a small cut stops bleeding. That's a very similar process. It happens in a matter of minutes right and now. That coronary artery is fully occluded. So, let's change the view a bit. If it takes slice of the heart, like it's the side being posterior or the back, and this being anterior or the front, with the left and the right ventricle here, and then we have three most commonly blocked arteries. The left anterior descending or LAD, which supplies blood to the anterior wall, and septum of the left ventricle, which accounts for about 40 to 50% of cases. The right coronary artery or the RCA, which covers the posterior wall septum, and papillary muscles of the left ventricle accounts for about 30 to 40% of cases. And finally, the left circumflex artery or the LCX, which supplies the lateral wall of the left ventricle, about 15 to 20% of cases. Notice that the majority of these areas supply the left ventricle. Most heart attacks, therefore, involve the left ventricle, where the right ventricle in both atria of the upper chamber aren't as often affected. Each of these areas is called the artery zone of perfusion, and if we take a closer look at one of these zones, we'll see that basically you've got the endocardium, which is the smooth membrane on the inside of the heart, and then the myocardium, all the heart muscle, and the epicardium, the outer surface of the heart, which is where the coronary arteries live. Let's say the lead gets blocked. The area of perfusion is now at serious risk, and within about a minute, that muscle cells in this zone don't see enough oxygen and become ischemic, and the muscle layer's ability to contract is severely reduced. This initial stage is extremely sensitive since the ischemic damage to the cells in the perfusion zone is potentially reversible. After about 20 to 40 minutes, the damage starts to become irreversible and the cells start to die, and the zone changes to the zone of necrosis or dead tissue. Once lost, those cells can never return or regrow. That's why quickly identifying and treating an MI is super important. The first area affected is the inner third of the myocardium, since it's the farthest from the coronary artery in the last area to receive blood and is subject to higher pressure from the inside of the heart. If the blockage suddenly lies or breakdowns in the blood flow returns, sometimes patient time will be limited to the inner third, and this would be called a subendocardial infarct. An ECG or done at this point typically shows an ST segment depression, or in other words, it doesn't show ST segment elevation. So sometimes we call this an STAMI, which stands for non-ST elevation myocardial infarction. Other causes of this sort of subendocardial infarct would be severe atherosclerosis and hypotension, anything that ultimately leads to poor perfusion of the heart tissue after about 3-6 hours to the zone of necrosis extends through the entire wall thickness called the transmural infarcts. Up as ST segment elevation and ECG, which is why they're sometimes called STEMIs or ST elevation myocardial infarction. So, the difference between STEMIs and STEMIs is that NSTEMIs don't have ST segment elevation, and this is caused by a partial infarct of the wall, whereas STEMIs have ST segment elevation involve the whole wall thickness. Patients that have MI will most commonly have severe and crushing chest pain or pressure that may radiate up to the left arm or jaw. They might have diaphoresis or sweating, nausea, fatigue, and dyspnea. All of these are either a direct result of an end organ like the heart or the brain not getting enough perfusion. So think chest pain and/or from the sympathetic response from the body to help the heart work harder and preserve blood pressure. So think sweating and clammy skin. Many people also have referred pain where the nerves in the heart are irritated, but that pain can be felt in the jaw, shoulder, arm, or back instead. A major complication within MI are arrhythmias or abnormal heart rhythms, with the highest risk being immediately following an MI, since the damage or injury can disrupt how the cells conduct electrical signals kind along the same lines. Depending how much the contractile or muscle tissues affected, patients' hearts might not be able to pump enough blood to the body, resulting in cardiogenic shock. In the days following an infarction, the tissue around the infarcted area becomes inflamed. When it's invaded by neutrophils, which can lead to pericarditis, inflammation of the pericardium. In the next couple of weeks, macrophages invade the tissue, and the healing process begins within the formation of granulation tissue, which new connective tissue that's yellow and soft. At this phase, the tissue most at risk of myocardial rupture. After 2 weeks to several months, the cardiac tissue scarring process finishes, and the resulting tissue becomes grayish-white in color. Since the scar tissue doesn't help pump blood over time, the remaining heart grow, muscle, or change shape to try and compensate for these lost cells and pump harder, but they ultimately continue to face quick recap heart attack, also known as a myocardial infarction, or MI, is the death of heart muscle cells due to the lack of blood flow, most commonly caused by atherosclerosis of the coronary arteries. The most common symptoms of myocardial infarction include crushing chest pain or pressure that might radiate up to the left arm or jaw, sweating, nausea, and dyspnea. Treatment of myocardial infarction includes reestablishing blood flow using medications, angioplasty, or percutaneous coronary intervention, but underlying risk factors should be addressed for long. Angina comes from the Latin angere, which means to strangle, and pectoris comes from practice, meaning chest, so angina. Pectoris loosely translates to strangling of the chest, which actually makes a lot of sense because angina pectoris is caused by reduced blood flow, which causes ischemia to the heart muscle or a lack of oxygen to the heart, almost like the heart's being strangled, which causes terrible chest pain. Stable angina or chronic angina is the most common type of angina, and it usually happens when the patient has greater than or equal to 70% stenosis, meaning 70% of the artery is blocked by plaque build-up. This small opening that blood flows through might be enough to supply the heart during rest, but if the body demands more blood and oxygen like during exercise or stressful situations, the heart has to work harder and therefore it needs more blood and oxygen itself. It's during these times of exertion or emotional stress that people with stable angina have chest pain, since the blood flow isn't meeting the metabolic demands of the heart, muscle, or myocardium, but the pain usually goes away with the rest. In the majority of cases, the underlying cause of stable angina is atherosclerosis of one or more of the coronary arteries, the arteries supplying blood to the heart muscles. Other heart conditions that might be disabled angina are ones that cause a thickening heart muscle wall, which would require more oxygen. This increasing muscle size can be due to hypertrophic cardiomyopathy from a genetic cause, result from the heart having to pump against higher pressure, as is the case in aortic stenosis, which is a narrowing of the aortic valve or hypertension. These larger seeker heart muscles require more oxygen. If the patients can't meet the increasing demands, they feel pain in the form of angina. Whatever the case, the heart needs blood, and if we look at the heart wall, there's three layers: the outermost layer, the epicardium, then the myocardium in the middle, and the endocardium inside the heart. The coronary arteries start up in the epicardium and then dive down and supply all the heart tissue. If blood flows reduced or the myocardium is thicker, blood has a harder time reaching the deeper layer just under the endocardium, called the subendocardium. Therefore, the classic finding with angina, subendocardial ischemia, meaning less oxygen is reaching the region just under the endocardium. This is Guinness thought to trigger the release of adenosine-rata-kinan and other molecules that stimulate nerve fiber in the myocardium that result in the sensation of pain. The chest pain is usually described as feeling like pressure squeezing, and it can radiate to the left arm, jaw, shoulder, and back, and sometimes is accompanied by shortness of breath, then diaphoresis or sweating. Usually the pain and symptoms last thus 20 minutes and subside after the exertion or stress is taken away, and therefore the heart muscle isn't demanding as much blood. Now, unlike a stable angina, which describes when patients have pain only during period of exertion or stress but not during rest, there's also unstable angina, which is when patients have pain during exercise as well as during rest. It never really goes away. Unstable angina is usually caused by rupture of atherosclerosis, meaning a blood clot forms on top of a mound of plaque. Although the occlusion might not block the entire vessel, there's now even less room for blood to flow by, and the heart tissue is starting to grow. Even when pumping at a normal rate, unstable angina, for the same reason as stable angina, includes self-endocardial ischemia, and it should be treated as an emergency because patients are at a high risk of progressing to myocardial infarction or heart attack. The key distinction is that unstable angina means that the heart tissue is alive but ischemic or starving for oxygen, whereas myocardial infarction means that the areas of the heart tissue have already begun to necrosis or die now. A third of type of angina is vasospasm angina, also known as prinzmental angina, and patient may or not also have atherosclerosis, ischemia, and resulting chest pain is due to coronary artery vasospasms, meaning the smooth muscles around the arteries constrict extremely tightly and reduce blood flow enough to cause ischemia. Episodes of vasospastic internet don't correlate with exertion and can happen anytime, including at rest. The underlying mechanism causing vasospasm isn't well understood but likely involves facial constrictors like platelet thromboxane T2. Unlike both stable and unstable angina, in this case, the coronary artery is constricted so severely that all layers of the heart wall being supplied are affected. Therefore, it is referred to as transmural ischemia. Alright, so if we line these three up side to side, there are some important clinical similarities and differences. First, it's super important to remember that in each case, the injury to cardiomyocytes isn't permanent, meaning it's reversible, and the cardiomyocytes don't die, which is how it differs where myocardial infarction on an electrocardiogram or ECG, both stable and unstable angina is low. An ST segment depression since ischemia is limited to the subendocardium. In contrast, vasospasm angina shows ST segment elevation due to transmural ischemia. Rest tends to relieve stable angina, whereas unstable angina is vasospastic angina, can happen anytime, including at rest. In terms of medications, all three can be treated with nitroglycerin, which is a vasodilator that increases blood vessel diameter to allow more blood flow. In addition, vasospasm angina also responds to calcium channel blockers.